everyone. Vikas usually gives the most boring talk to the most boring speaker. So this is some basic science. We are surgeons, we don't like basic science. So I will try to give you some basic principles and as much as possible provide some clinical relevance to that. So it's about fracture healing. In the perfect case of perfect anatomical stable reduction, you can get direct healing, which means there is no callus, and that's what we call direct healing. Usually we are facing the whole process of callus formation, which goes in 5 stages, which is indirect healing, and that's what most of this talk will be about. So these 5 stages, to start off with, as an overview, you first have the moment of impact, which is within milliseconds of the trauma, which causes the fracture, which then is followed by hematoma formation and inflammation, which takes the first hours of the fracture. After that, there is the first stage of callus formation, soft callus formation or fibrocartilaginous callus formation, which takes up to 3 weeks, which then the soft callus is replaced by hard callus. So you have the bony callus formation, which is the 4th stage. And finally, taking up to years is the stage of remodeling. So, first stage is the stage of impact. So there is a threshold for bone to fracture, which is related as well to the patient. You can have, and that's the graph on the left side, a young male guy will be able to sustain more stress at the bone before fracture, whereas an older female osteoporotic woman will take much less effort to fracture, which is quite obvious, I guess. So some smaller remarks to that. First of all, bone is viscoelastic, so there is stress relaxation, and fracturing or not fracturing is related to time-dependent behavior. Maybe more important, the resistance to bending and torsion, it's dependent on the radius of the bone to the 4th, how do you call it, power. So the bigger the guy, the bigger the bone, to the 4th of the power, the smaller the risk for fracturing. If you have a small female osteoporotic with a small canal, it takes to the 4th of the power risk to fracture. You remember this, to the 4th power risk factor. So the second stage is the stage of hematoma formation and the inflammatory response. So upon the impact, upon the fracture, you get blood vessels that are damaged and you get a clot. This process takes the first hours. It gives swelling, and after the hematoma formation, there is this inflammation up to death of cells. Together with that, there is removal of that tissue by macrophages, and this initiates the entire process of healing. So some small remarks to this process. The entire clot formation is dependent on the fracture itself, the type of the fracture. The more blood there is, the better the hematoma formation is. With this release of healing products, there can be systemic effects as well, leading up to pulmonary injury or organ failure. So that happens as well with severe trauma. The inflammation stage is primarily represented by 4 major events. So there is vasodilatation, there is increased permeability to allow cells to go there, there is activation of cells by the products released, and there is adhesion of immune cells. I will go through that. So, what you should remember, most importantly, there is an important need for blood supply to initiate fracture healing. And that's very important. That's a takeaway message. So the blood supply, it comes from several sites. There is endostal blood supply, the inner 2/3 of the bone. There is periostal, it's the outer 1/3. And all of them get ruptured by the fracture or by the surgery. During the treatment, we affect this blood supply. So with reaming, we damage the endostal blood supply. With plating, we damage the periostal blood supply. So even if we try to treat it, we are actually messing up with the natural healing process and decreasing that process. So your surgery, do it carefully. And second of all, besides the importance of bleeding, there must be appropriate inflammatory response to heal. So some clinical remarks to that. There is some debate about the importance of non-steroidal because it reduces the vascularity, but it affects as well the inflammatory response. And most people claim not to use them. In fact, the so-called COX-selective non-steroidal drugs are even worse than the regular. So that's for some clinical remarks. And then again, inhibition of healing. There are some drug and patient-related factors. So as we know, there is importance of bleeding and there is importance of inflammatory response. So whatever affects those will affect the healing process. So patient-related inhibition of healing, there is diabetes, there is immunocompromised patients, elderly, anemia, malnutrition, and in terms of medication, non-steroidal have been proven to decrease the healing process. Corticosteroids, statins, smoking is important, and even nicotine replacement can affect the healing process. And alcohol is debated, of course. The third stage is the soft callus, the fibrocartilaginous callus formation. It takes about 3 weeks. So you steadily get ingrowth of new capillaries. There is transition from the clot to granulation tissue, a procallus, and then fibroblasts and osteogenic cells invite this procallus. There is collagen fibers connecting and chondroblasts starting to produce the soft callus. Cartilage, fibrocartilage produced by fibrochondroblasts or chondrocytes usually consists of type 2 collagen. We are all familiar with what cartilage is. Importantly, it's avascular, so there are no blood vessels there. And nutrients get there by diffusion, and it's very resistant to compression. So following the soft callus formation, you get finally the transition to bony callus, which takes about 3-4 months, starting after the cartilaginous phase, where osteoblast starts to replace the fibrocartilage with woven bone. In contrast to cartilage, bone is vascularized. And completely at the end, there is the remodeling phase. There is restoration of the original bone in size, shape, and strength. This process takes about years. Callus consists of woven bone, whereas the final strong bone, the remodeled bone, consists of lamellar, mature bone. And that's the remodeling phase. So this is an overview of the timing of the different phases. So inflammation, the first 3 weeks. Reparation, soft callus formation, starting after 2-3 weeks. And remodeling, taking up years. Another summary. Some minor remarks, clinically related. So healing time, it's quicker in cancellous bone than in collateral bone, which is due to the rich blood supply. Different fractures heal at different rates. impacted fractures can heal in several weeks, whereas displaced fractures can take months or years. Bones of the arm may take 3 months. The longer bones, the tibia, femur, can take up to 6 months and longer. The more surface area is available for healing, the faster it can unite. Spiral fractures have a larger surface area and they're unique, quicker than transverse fractures. Vascularization, as already said, it's tremendously important, especially in the first stages, but as well at the end. If both fragments have a good blood supply, the fracture will heal. If one of both sides has reduced vascularization, you might be facing delayed union. Don't forget that vascularization can be compromised by swelling or by cast treatment or whatever. You need to get your fracture, or you need to maintain it vascularized. Thank you very much for this basic part.